far, far, far away from remission by the time they come to the rheumatologist. And when we have just mentioned that for the damage is maximum in the first year, and the disease, our aim should be to bring the disease control within 6 months to a year. So what is true remission then? True remission is state of no detectable disease and no progression of structural damage on imaging. And we just saw those wheelchairs and they are nowhere near remission. And wide remission, we just talked about it. This is a good slide which shows us the correlation between synovitis and erosions in individual joints. And this is what we see, that persistent synovitis, the higher the score, the sharp score, the greater the synovitis, greater the progression on X-rays. So we have to control synovitis so that we can decrease the damage, structural damage to the joints, and thereby reduce the disability. So true remission will prevent disability and improve quality of life in patients with ARC. So whenever the patients are seen in the clinic, our goal should be that we should regularly monitor the disease activity and also their adverse events. The count, the disease activity score, DAS-28 or HAC, or EULAR, their guidelines for assessing the patients who come to your clinic to assess whether they are active or they are in remission. So today our trial is the study on rituximab, and we were interested in rituximab as compared to other biologics because it's less expensive. It is like half the price of anti-TNFs, and also because, as we say, that it is basically a B cell, a CD positive, an antibody which is directed against the CD positive B cells, and the risk of having tuberculosis, which is more in our country, we desired that we should have a biologic in which the risk of tuberculosis is less as compared to other biologic agents. So basically, as you see here, that this is a murine antibody and a human antibody which is IgG derived, and this is the murine component and this is the human component. Now how does it act? It is an appropriate B cell antigen. CD20 is an antigen which is not expressed on the stem cells, on early pre-B cells, on dendritic cells or plasma cells. And this is very clearly shown over here, that the CD20 antigen against which this antibody is directed is not expressed on the stem cells, and it is not expressed on the plasma cells and not on the pro-B cells. And this explains the mechanism of action of this, because you basically do not lose the capacity to mount an immune response if you would knock out all cell lines, including the plasma cells. So how does it act? It binds to the B cell surface of the CD20 antigen, and then the human derived region activates a cellular mechanism which initiates the B cell depletion. And we clearly know now that B cells have a role in rheumatoid arthritis. So by these mechanisms you can lead to B cell depletion. And how does that work? It is by complement mediated cytotoxicity, cell mediated toxicity, and apoptosis. So what happens is, how does it deplete the B cells? By binding to the B cells, it activates the complement system, and when the complement system is activated, it leads to the lysis of the B cells by forming these pores in the membrane. So the other action is by Binding to macrophages. What happens is that when it binds to the macrophages, it releases